Hey, Section 9. Hope you are all doing well as we gear up for Block 4. But before we do that, I'm going to brighten this up a little bit. Before we do that, let's wrap up Block 3. So again, I enjoyed reading everyone's thoughtful posts and some of the discussion that ensued from it. Hopefully, I was able to stimulate a little extra conversation about some of these topics. They are definitely an area of interest in mine, and some things that just kind of get my goat. And hopefully that came across. I don't want to come off sounding too kind of crazed about some of this stuff, but some of this stuff is really some of this stuff bugs me, to say the least. And if it came off sounding too annoyed, then my apologies. So treatment of ACL tears. So, I think the Frobel article is a seminal article. I will say that I think you need, when you read articles like this, it's not only important to appreciate what they're saying, obviously what the research is telling us, but where the article was published. This article was published in JAMA for a reason. It was reaching out to primary care. This article was not meant for orthopedic surgeons. This was not to tell them that they need to be considering conservative management, because the bottom line is they have their own inherent biases, and they probably aren't going to consider conservative management. As a matter of fact, there's a good chunk of orthopedic surgeons who would probably vehemently disagree with it. Some of the younger ones that have come out are probably going to be a little bit more on board, but this was geared toward primary care. And so what I would say is, this is not something you take to an orthopedic surgeon and say, see, I told you this as an opportunity. I told you this, that we could be effective prior to surgery. This is somebody you take to primary care and say, in your referring physicians, if you have somebody who has torn their ACL and you think conservative management may be a better option for them, feel free to send them this way, because we have tools that can help them return to a normal level of activity depending on what they're experiencing, that may not require surgery. And my God, I mentioned a couple of different times in some posts, I saw people in their early 30s who their only goals was return to walking and maybe some yoga. And they were deciding whether or not they should have surgery. And in their minds, they were broken. And the only way to fix themselves was to return to was to get this thing fixed. And two of them, of the three or four that I think of, had 6 weeks of prehab, if you will, and were doing really well. Didn't matter. Okay. Copers versus non-copers. The biggest problem is that we just don't know who the copers are versus the non-copers, and we can't tell you until 3 months out. That's about when we're able to really know if you're going to experience any shifting. So that's a problem. Performance-based testing. I think we learned that the triple hop, the single hop, it's good, it's helpful, but it's by all means not at all the end-all be-all. And the new research says that basically patients shouldn't return to sport for 9 months. And that doesn't mean they shouldn't be training, because that's another thing that kills me, is that people are really good like the first 6 weeks, and then the crutches come away, and the bandages come off, and the stitches heal, and there's no more straight leg immobilizer, and everything starts to feel a little bit normal, and they stop losing focus, and they don't continue to challenge themselves, and their leg doesn't get to be where it needs to be. And at 3 months, they think they're just done, and they aren't done if they want to return to rec soccer, rec basketball, anything that involves east-west activities. And we don't have, our performance-based testing is good, but it's not great. And I had a guy who was a collegiate level soccer player who was able to do the test. He actually did better on his involved leg than his uninvolved leg. He returned to sport at 7 months, and at 8 months he retore his ACL. And that killed me. He worked so hard and was doing so well, but he was playing on turf. He had his deep cleats in, and he was really playing at a high level. He wasn't in college anymore. He was 27, but he was playing a high level soccer. And did he need to do it? And now he's debating about whether he wants to have it redone or not. Anyways, so dilemmas. Nioe. Use of manual techniques in exercise, I think, are helpful. I think that they can reduce pain. They're very short term. People mentioned that in their original post. You use manual therapy as a short term bridge to exercise. That's the bottom line. Booster sessions. I think booster sessions are important. I mentioned in a number of original posts, I think that booster sessions and telemedicine could be really helpful for people with more chronic types of conditions, whether it's knee OA, hip OA, or chronic low back pain. I think telemedicine, people just need to be able to bounce ideas. They need to be able to feel safe. They need to be able to have the fear taken down. Things like booster sessions and telemedicine allow for that. It's where we offer a lot of value. And a lot of people can calm down. Too many people just stop doing their exercises because they go into a hole. And in a number of times I posted for some people this article, I can't think of the author, who did a study on rescue exercises, which was basically knee pain spikes for whatever reason, and they start to do more non-weight bearing or more isometric kinds of exercises. So there's some planking, there's some bridging, back to straight leg exercises and straight leg raises rather, just some stuff to do, because it's sometimes people either do absolutely nothing or they do a whole bunch, and there is a middle ground. And these rescue exercises, as they called them, proved to be very successful. So whether it's booster sessions, whether it's a phone call, whether it's rescue exercises, these are things that patients can use to their benefit to feel better. And last thing, patellofemoral pain syndrome, think regionally. Research shows that if you aren't strengthening up those hip abductors, you're missing out. I have two favorite exercises for that. One is a side plank on your knees to start with a leg lift. That is a money exercise for hip abductor weakness. And it's mostly on the side that's stabilizing versus a leg lift. Another one is I like to do either that kind of a monster walk or a crab walk, or just some hip abduction with a TheraBand. And it's not even the moving leg, it's the stance leg in that case, where you're just standing and doing some hip abduction with resistance from a TheraBand. It totally gets worked. And after about 15 repetitions, man, they are done. And I love it. I love that. So I really like, and then, even some manual therapy. Now I showed some people some CPRs that involve the lumbopelvic manipulation, and those are really not great at all. Basically, it's, is there a reason to do manual therapy above and below? And I think that there is, especially if it's an impairment-based model. So remember, it's not just about patellar tendon tracking. And in some people, I shared an article where patellofemoral tracking, where people were tracked medially, or they were taped medially, they were taped laterally, and then they were just taped in neutral. They all did better. Is tape really repositioning the patella, or are we creating some kind of proprioceptive input that reduces the nociceptive signal? More than likely, that's probably what's happening. It's always about tricking the nervous system. All right, enough on that. But I really enjoyed the interactions, you guys, and hopefully I created some discussion and some thoughtful... I'm going to say one more thing about the ACL stuff. Why do surgeons give you protocols? I'm just going to challenge every one of you. You should be doing the protocols based on evidence-based medicine, and you should be perhaps asking for some input after you formulate them or working with them. But this whole notion that they they do their fellowship training, and then they use this protocol that they get out of fellowship training and that they hand you is ridiculous. You're the expert when it comes to postoperative care. Why are you telling them how to tie, whether to use a hamstring graft or an allograft or a patellar tendon graft, or that bugs me. So what I would suggest is you work with your surgeons as a group, formulate the best practice, and there's best practice out there in regards to post-op rehab, and that you're making the call, and you certainly can include them, but we need to long are the days gone by that surgeons hand us something and say, this is what you should do. It just makes no sense. All right, sorry, I'm getting off my high horse. Looking at next block, evidence-based management of selected foot and ankle disorders and return to sport considerations. Interesting conversations about when people go back to sport, and then the whole foot and ankle thing, right? Those people can be really, they can be tough, especially if you haven't really gotten a really good understanding of what's happening. We're going to have a patient case that we're going to work on. Please always contact me with any questions. Love to hear your thoughts. If there are any concerns, we've had a number of people have had some things come up. Please reach out and let me know. Don't let me be the one to contact you and say, hey, what's going on? Where are you at? Please contact me. Let me know what's going on. It just makes my life a lot easier. Okay. James will be moving over to the Delta group, and I'll be taking Charlie for the final week, or the final block rather. I am headed to AOMPT on Thursday of this coming week, I guess next Thursday till Sunday. So if you're there, let me know. Reach out. Love to hook up with you while we're at the conference. It's one of the favorite things I do all year. I love going to hear all the great speakers and interact with just some of the great minds at AMP. This will be my 7th year going, and I don't think I wouldn't miss it. So I will be kind of indisposed, if you will, but certainly checking in and making sure that everybody gets their stuff done on Sunday. You guys have a good rest of your weekend, and look forward to getting back to the boards for one last time a week from today, or I guess a week from Sunday. Take good care. Bye-bye.